Hi, let's learn more about other members or other family members of arbovirus family. So in the earlier presentation, we learned about the characteristic features of arbovirus and their taxonomy classification. We also know that arbovirus can be classified based on their kind of infection they are causing, kind of clinical presentation, and also based on some local names by which they are known, right? So we'll be mainly focusing on taxonomic classification, where we classified them into different groups, almost 7 different groups, right? They includes Toga viridae, Flaviviridae, Bunia, Rio, Rhabdo, Arena viridae, and Filoviridae. So let's learn more about this one, Toga viridae family, and we'll be mainly focusing on alpha virus category, which includes chikungunya virus and equine encephalitis causing viruses. Right, so these are their basic characteristic feature is they are spherical virus, 17 nanometer size, and they are enveloped virus with which they got a single stranded RNA as their genetic materials. Right, so they are spherical enveloped RNA virus. So being enveloped means they are highly resistant to our immune system, or immune system fail to identify them as a foreign particles, because these viruses are getting these envelope from our own cells itself. And they have a capsid which is composed of 42 capsomeres. 42 individual proteins are making this capsid. I'm talking especially about Togaviridae family. And they got viral envelope, which is the lipid envelope, and it is having two important glycoprotein spikes, right? One is having hemagglutination activity, and one may have sometimes they may have neuraminidase activity also. So hemagglutination activity is the primary function of these surface receptors present on the viral envelope of Togaviridae family, and viral replication happens in cytoplasm and release the newly formed cells by a process called budding through host cell membrane. So the newly formed viral particles will literally bud out from the host cell membrane by taking few amount of host cell membrane. Now, if we specifically learn about Toga viridae, we can understand the fact that Toga viridae includes two important main virus: alpha virus, which is the most prominent disease-causing virus, and we have few other types of Toga viridae, but they are usually causing infections or complications in animal sources. So we'll be focusing mainly on alpha virus. Now, alpha virus itself is again can be divided into two main groups. The group of alpha virus, which can cause fever and along with arthritis, right? So they are chikungunya virus. The important one is chikungunya virus. Other than that, there is other members like Onyong virus, or ONN virus. So, but the major alpha virus which can cause fever and arthritis will be our chikungunya virus. Now, the second category of alpha virus is something which causes encephalitis, right, which comes under this category: equine encephalitis, Western encephalitis, Venezuelan equine encephalitis virus. All those comes under this category. So we'll be mainly focusing on alpha virus and specifically chikungunya, right? So alpha virus is again subdivided into two types. One is fever arthritis group. This is the fever arthritis group, and this is the group which causes encephalitis, right? So let's learn more about chikungunya virus. Now, talking about chikungunya, chikungunya is named from a local language, which is really existing in African country like Tanzania. So the first case of first reported isolation happened in Tanzania in 1952. It's a re-emerging viral disease which is characterized by severe acute fever with severe arthralgia. So it's a re-emerging viral disease. Means it was there earlier. Somehow we managed to stop it by vector control, not by effective vaccination, but by vector control we try to stop their further spread. But now it is being coming as a re-emerging viral infection. So every year there is a season where chikungunya come up with serious complication. Now, the word chikungunya came from the word, from a native word from Tanzania, for the patient, in which the patient lies up doubled up due to severe joint pain. The patient will have severe joint pain or arthralgia, which is associated with chikungunya along with high fever. It came in India as in different formats like epidemics in 1963 in Africa, and even these days as well. There is some localized epidemics happens across the country. It's commonly seen in tropical countries, including India. So, talking about the transmission of chikungunya virus, human act as a normal reservoir, that is urban cycle. There is no specific animal reservoir, but it's believed that it is also prevalent among monkeys with the sylvatic cycle, right? And the vector for this particular viral infection is Aedes aegypti. That's a mosquito which usually bites during the daytime. So female Aedes aegypti mosquitoes, during their blood meal, they can inject a few number of virus through their saliva into the human body, and that is something the start of the viral infection. And this virus will now start multiplying within the reticuloendothelial system, and from there it develops into large numbers, causing primary and secondary viremia. And transmission usually also happens during blood transfusion and organ transplantation. So these are two other reasons for transmission of chikungunya infection. One is improper blood transfusion, and second one is improper organ transplantation. Right? That's the speciality of chikungunya virus. Now we'll be mainly focusing about the urban cycle where human beings are involved. Human act as the reservoir, and Aedes aegypti can act as the vehicle or carrier of this viral infection, which can enable the transmission of infection from one patient to another healthy individual, right? And if you talk about the clinical manifestations associated with the chikungunya virus, they follow the same pathway. They enters human body during the blood meal, and they enters into reticular endothelial system. They started multiplication over there, and they comes out in large numbers by budding from host cell, so they can easily escape from host immune mechanism. Now, talking about the clinical manifestation, the incubation period is usually within 3 to 7 days. So, it's a very short incubation period for this virus. And the common symptoms includes fever with severe joint pain, crippling joint pain. The patient will usually double up with severe pain along with lymphadenopathy, and in some cases there will be conjunctivitis. And it is also characterized by a maculopapular rash, which is really common. And arthritis, of course, is associated. Arthritis or arthralgia causing viral infection. Arthritis is a common feature where polyarticular, migratory, and edematous joint swellings are commonly seen, in chikungunya condition. Polyarticular, migratory, and edematous joint swellings are common feature of chikungunya viral infection. It's mainly seen in small joints of wrist and ankles. That starts from there, but it spread to other areas also. The other symptoms includes other non-specific symptoms includes headache, muscle pain, and even skin rashes. There will be hemorrhagic manifestations if there is a further delay in the process. It is typically a biphasic fever which recurs after 1 to 6 days. That's the most common feature for this infection. It's a recurrent viral infection, and there is no effective vaccines available for this viral infection. And the major risk groups includes newborn babies, even older people who are above 65 years of age, and people with hypertension, diabetes, and heart disease are having high risk of getting severe complication associated with chikungunya virus. Now, talking about the lab diagnosis, we have mainly serological examination. We can collect a blood or serum sample from the patient, and virus isolation of course is possible, but we have to grow them in mosquito cell line. That's a difficult part, so we won't usually do virus isolation. So what we commonly do is serological examination, where we will do indirect ELISA to identify the presence of IgM or IgG antibodies in patients. So we'll look for the presence of either IgM antibodies, which shows immediate kind of infection, and if you identify IgG antibodies, that is shows a latent infection. And of course, we can go for molecular diagnosis or even PCR. And talking about the prophylactic measures, there's no specific prophylaxis is available. Vaccinations are always under the trial. Unfortunately, it's still under the trial, and the best method is fogging or vector control is an effective method to prevent these kind of viral infections. So the next important family which is coming under arbovirus is flaviviridae or flavivirus. Let's learn more about their features and the common infections caused by flavivirus. Now I can say in simple words that flavivirus is the dangerous member of a dangerous family member of arboviral superfamily. So it can cause there are two different types of flavivirus. One which can be transmitted through mosquitoes, and we name them as mosquito-borne flaviviral diseases or mosquito-borne flavivirus. And there are another class of flavivirus which can be transmitted through by the ticks. So they are known as tick-borne flaviviral infections. So mosquito-borne flaviviruses can transmit serious infections which can lead to encephalitis and febrile illness, and even tick-borne flavivirus can also bring the same kind of clinical presentation, encephalitis and febrile illness. Or in short, the two commonly seen clinical presentation associated with the flavivirus includes encephalitis and severe febrile illness. That means it can severely affect our central nervous system, or it can cause a multi-system failure or a systemic complication which is followed by severe acute to chronic febrile illness condition. So this is a dangerous family member of Arboviridae. Let's talk about the mosquito-borne flavivirus. I'm talking about this one. Of course, only the vectors are different, but the clinical presentations are almost the same with varying degree of severity. So let's learn about mosquito-borne, flavivirus. So mosquito-borne flavivirus can bring encephalitis and can also cause febrile illness. Right, the common mosquito-borne flaviviral family which can cause encephalitis includes, or the diseases includes Japanese encephalitis, which is the most serious clinical disease, which is caused by Culex mosquitoes. So, mosquito-borne flavivirus can cause different varieties of encephalitis. The common one will be Japanese encephalitis. Of course, this has some connection with the geographical area where it has been identified for the first time, and this is the most serious clinical disease which is caused by the Culex mosquitoes. Other examples includes Murray Valley fever, West Nile disease, and St. Louis viral disease, and all of them are coming under mosquito-borne flavivirus family, which can cause encephalitis kind of condition. Now, febrile illness is mainly seen in yellow fever condition. Yellow fever is one example. Dengue, that's the most commonest and the most common flaviviral infection in India. Right, so comparing all these things, dengue is the more common flaviviral mosquito-borne viral infection in Indian subcontinent. So let's talk about tick-borne flavivirus. Tick-borne also can bring a encephalitis condition, which is example is Povsan, and febrile illness is caused by Casanova forest disease (KFT), Omsk hemorrhagic fever. These are tick-borne flaviviral infection, which is transmitted by ticks, not the mosquitoes. Right. So I'll be mainly focusing on Japanese encephalitis now. Japanese encephalitis is, it's named after the first incident which has been reported in Japan, and which is also common. Which is also commonly seen in South Asian countries. So the first case of Japanese encephalitis was reported in 1871. That's why it is called Japanese encephalitis. And in 1935, virus was isolated in Japan. In 1955, it is also reported in India, especially from Vellore, right, Tamil Nadu, and even in Pondicherry. So the transmitting vectors are Culex mosquitoes. Culex vishnui and Culex whitmori are the two important species of Culex which can cause the transmission of Japanese encephalitis. And mosquitoes shows trans-ovarian transmission. And it's also seen in water birds like ergots and herons can also cause the transmission of infection, or they can act as reservoir host for this viral infection. Right, so the amplifier host is usually pigs. Japanese encephalitis virus multiply exponentially in pigs without causing any manifestation. So pigs can act as reservoir host for this viral infection, and if once it reaches the human body, that is the dead end of this infection. And the age group, the common age groups which are having high risk of getting this infection includes children below 15 years of age and people above 65 years of age are also susceptible to get the Japanese encephalitis at a higher rate. And incubation period is just like short like any other arboviral infection, 5 to 15 days. So that's a shortest incubation period which is required for this virus to show clinical presentation. Now, talking about the clinical presentation, majority of the infections are asymptomatic, provide the fact that it is appearing in a healthy individual, but prolonged exposure even to healthy individual can bring serious clinical presentation. So there will be subclinical infection and there will be clinical infection. Subclinical infection will be usually asymptomatic, or there will be non-specific symptoms like normal fever of change in temperature, etc. But exact clinical presentation or specific symptoms includes prodromal stage, which is characterized by severe febrile illness, and there will be acute encephalitic stage, and early symptoms are usually non-specific. There will be abrupt onset of fever, headache, vomiting, and we already discussed about this. And there is a chance of enzootic cycle between, which is happening between pigs and the mosquitoes. Human infection is the dead end of this infection, right? And there is CNS symptoms, or CNS complication. That's the most dangerous aspects of encephalitis, Japanese encephalitis condition, which is commonly characterized by convulsions, behavioral changes, even meningeal signs, including paralysis. So these are the serious CNS complications associated with the Japanese encephalitis. All right. So the incubation period is just it start appearing within 6 days after the entry of the virus, and there will be nuchal rigidity, convulsions, altered sensorium, coma, and even it can lead to the death of the individual. That's a CNS complication. Fever is high with continuous reappearance of feverish condition. Mortality rate is 50%, and if it affects the high risk age group, definitely the mortality rate will be above 80%. And there will be residual neurological deficit in 50% of the survivors that can create long lasting complications in individual, right? And if you check CSF sample, there will be increase in sugar or protein level with pleocytosis in CSF sample. That is one non-specific lab diagnostic approach. I mean, a point which we can use it for lab diagnosis purpose. Talking about the lab diagnosis, the best sample will be definitely the blood sample. Right, we can take blood sample or CSF sample from the individual, and which shows neutrophilia with CSF abnormalities. CSF abnormalities means increase in sugar levels, increase in protein levels, and we can also go for isolation of virus from CSF, but that's a long tedious process. So we are dependent on serological examination, where we can do hemagglutination inhibition, neutralization, antibody test, or the commonly used method is ELISA, where we will go for IgM capture ELISA. We will try to target IgM antibodies. If you identify IgM antibodies, that shows a early stage of infection, and if you identify IgG antibodies, that's a latent phase of infection. And we can do this, or we can identify IgM antibodies from both from CSF sample and even from serum sample. Herons act as the reservoir host. Amplifier host is domestic pigs, where they will not be any kind of symptoms, so they can carry this infective agent on a larger scale. And there is an enzootic cycle happens between pigs and mosquitoes. I mean, transmission of infection. Human infection is the dead end of this infection. Now, prevention of Japanese encephalitis is limited. I mean, of course, we have some specific vaccination available, but apart from taking this vaccine, vector control or carrier control is the best method to prevent these kind of infection spread. So vector control measures includes fogging or clearing this stagnant water to avoid mosquito propulsion and all those. That's a easiest method. And we have vaccines available. Active vaccination is available, where we have two types of vaccine. One is the inactivated vaccine, or live attenuated vaccines are also available, which can be used to prevent serious complications associated with the Japanese encephalitis. And for inactivated vaccine, we are using Nakayama strain, where we'll give 2 doses at 2 weeks interval. Primary dose is 1 ml, 0.5 ml for children below 3 years of age. Booster dose should be given after 1 year of time. And during the outbreak, another booster dose is definitely required in case of inactivated vaccine. So in a live attenuated vaccine is much more significant than inactivated vaccine, because booster doses will not be required in case of live attenuated vaccine, that is produced by growing this virus in baby hamster kidney cells. from Japanese encephalitis strain, and we can give 2 doses 1 year apart. That will be sufficient to provide a good amount of immunity, and it gives cross immunity to dengue and West Nile fever also, because these are also causing similar kind of complications, right? They are also coming under the same family, so the same vaccines prove to be effective against dengue and West Nile, but it will not provide 100% protection, but it shows on a larger scale. They provided people who received Japanese encephalitis vaccine showed good resistance against dengue viral infection as well. So vaccination is always given to people or population who is under the severe risk of getting this epidemic or endemic. And in endemic area, all children below the age of 15 years must get this vaccination. And vaccination is recommended 1 month before the anticipated epidemic if you suspect this kind of infection. For example, in South India, it is usually expected between September to January, and in North India, February to March. This is the season for getting this. There is a high risk of getting this infection in these periods. In non-endemic area, vaccination is recommended if vector density is increased or there is rise in antibody titer in population. It's always good to have a check about the antibody titer values and vector density in those areas to prevent serious complications caused by Japanese encephalitis.